Your body wisdom speaks. Do you listen? Body gives you messages and clues all the time about what is going on within you. Opinions are like wristwatches. Everyone's watch shows different time from others, but everyone believes that their time is correct. What is new in pulmonary critical care? Are there any recent advances in sleep medicine? I hereby invite Dr. Harjit Dumra sir for his talk on Year in Review in Pulmonary Critical Care. Sir is consultant pulmonologist and critical care specialist at KD Hospital. He is director, Sparsh Chest Diseases Center, Ahmedabad. Welcome, sir.
Thank you, ma'am, for those kind words of introduction. This session is based around a case, so I'm going to highlight some important aspects which happened in the post-COVID times primarily. Not going to focus on COVID. I'm also going to emphasize on certain investigations in therapeutic modalities which you might find exceptionally useful over the next couple of years, although they might be starting out right now, but they will show their true colors over the next few years. So watch this space over the next few years. So this is my patient. He's a 56-year-old male. He has a BMI of 30, smoker, several comorbidities, asthma, diabetic, hypertensive, rheumatoid arthritis with an interstitial lung disease. You can see his scans on the right-hand side. He has reasonable exercise tolerance at this point of time. He's on low-dose systemic steroids for the last several years and also is taking methotrexate, clearly indicating he's immunocompromised. Gets admitted with fever, cough, shortness of breath, which has been going on for the last 4 days. Comes to the wards, started on nasal oxygen. He's diagnosed as a patient with lower respiratory infection, probably viral etiology. His COVIDs are negative. This was last year. Started on co-amoxiclav. Besides this, he has uncontrolled diabetes, and he's diagnosed with HFpEF, heart failure with preserved ejection fraction. Routine treatment is started and he stabilizes over the next few days. Now he's about to get discharged, but on day 7, a routine investigation shows his hemoglobin as being 8.2 and he's transfused 1 unit of PCV. Few hours following the transfusion, this patient develops acute respiratory distress and has to be shifted to the ICU. Baseline vitals show he's tachycardic, he has a mild fever, his blood pressure at this point of time is on the lower side, although he does not need vasopressors. He's tachypneic, he requires 10 liters of oxygen. Several other investigations done. His PCT is in the range of infective process. His BNP is equally high. WBC counts are high. Creatinine is borderline. A blood culture is sent because at this point of time he's not producing sputum. This is his X-ray. These are the differentials. He's possibly suffering from transfusion-associated circulatory overload versus a nosocomial pneumonia. And remember, he's an immunocompromised host. And this is where we start the ball rolling. He's coming to the ICU. You have 3 options here. What do? Start him on high flow, give him NIV, or would you go for intubation and ventilation? We've been using the HFNO in immunocompromised patients for several years now. The Florari trial in the immunocompromised hosts clearly showed that if you use HFNO, it was better than NIV. There were other studies which have shown the same thing. Surprisingly, in the immunocompromised host, HFNO was equal to NIV. It was not inferior. This is surprising because we've been using NIV all along to avoid intubation in the immunocompromised population because of the risk of infections. And hence, we would believe that NIV would be superior. However, of late, we found that in patients on NIV, sometimes excessively large tidal volumes have been leading to acute lung injury, and this has been vitiating the results of patients on NIV. So is the time now? Should we substitute NIV with HFNO? Or even go one step forward? Should we combine HFNO with NIV? This was the trial which came out in the Lancet very recently in July of 2022, where they compared HFNO with non-invasive ventilation. And what they did was there was one group who was given only NIV, and there was another group where it was given alternating with HFNO. What was important was they excluded all patients who had type 2 respiratory failures who would have benefited for NIV. So patients of cardiogenic pulmonary edema, COPD exacerbations, post-operative patients, patients who were hemodynamically unstable were excluded. Also, they practiced safe NIV ventilation, which means they used maximum of 8 ml per kg of tidal volume. Remember, we are using low tidal volumes for invasive ventilation, but we should be doing the same for non-invasive ventilation. So this was the first trial which compared protective non-invasive ventilation against HFNO. The primary outcome was mortality at day 28. There were several other secondary outcomes. What came out was, if you used HFNO alone or HFNO with NIV, the results didn't make a lot of difference, which means that if you are using HFNO in the immunocompromised host, presently it is as good as using an NIV. However, there are several caveats to this. So what is the take home? First and foremost, as all of you do in immunocompromised patients, it is okay to go to an NIV. But in patients who have a high respiratory drive, there is a huge chance of self-inflicted lung injury by generating higher tidal volumes. So in those groups of patients, it is better to avoid NIV. HFNO can be a substitute in these patients. Also remember that in the patient subgroup with type 2 respiratory failure, COPDs, cardiogenic pulmonary edemas, post-operative patients, NIV might still be better than HFNO regardless of this trial. Also, if you use protective non-invasive ventilation, you avoid high tidal volumes in the NIV subgroup, then the mortality in both the groups will be possibly the same. So HFNO is not superior to NIV if you practice safe ventilation. So this patient was initiated on HFNO. This was a CT which was done just prior to rolling him into the ICU. As you can see, there are dense consolidated shadows in the dorsum of the lung. Now the question is, this patient is on HFNO. Would you classify this patient as having ARDS? Till date, we have used ARDS definitions to classify patients only if they are on NIV or invasive mechanical ventilation. The Berlin definition clearly showed that a patient needs a CPAP of 5 for you to classify him as mild, moderate, or severe. So it is not possible to classify a patient as having ARDS without PEEP or CPAP. But times are changing. A lot of our patients are on HFNOs, and we have seen that it is not the device but the oxygenation level which dictates the severity of the disease. So is the time right to modify this definition and include HFNO in the Berlin definition of ARDS? So Michael Mathey and his colleagues in the Lancet in 2021 proposed this new definition or modification to the Berlin definition, where patients treated with HFNO with at least 30 liters per minute, who had bilateral infiltrates documented by X-ray, and who had a PF ratio less than 300 can now be classified as having ARDS. There are still several questions whether 30 liter is the appropriate cutoff. Should the duration be increased from 7 to 14 days? Because in the COVID era, a lot of patients developed ARDS in the second week, while the ARDS definition wants us to have it in the acute setting. Should SF ratios be the norm? And should we classify patients with multiple quadrant involvement in the same lung rather than bilateral involvement as patients with ARDS? And these are some questions which will be addressed in the near future. So for the time being, what I want you to take home is, a lot of my colleagues believe that if a patient is on HFNO, he has mild disease. A patient is on invasive ventilation, he has severe ARDS. This is not a norm. A patient of HFNO on a 90% FiO2 with a flow of 60 can have severe ARDS, vis-a-vis a patient who is on invasive ventilation with an FiO2 of 40% is a patient of mild to moderate ARDS. So the machine does not dictate the severity of the ARDS. It is the PF ratios which dictate. So please be worried that when you have a patient of ARDS on HFNO, this patient might still be a very severe patient. You might have to graduate directly from an HFNO to an ECMO. So it does not mean that going from HFNO to NIV to ECMO. Patient on HFNO deteriorates, intubate, ECMO. So this patient was managed with HFNO. He deteriorated at 24 hours, ended up getting intubated and ventilated. We did an echo on this patient, grade 2 diastolic dysfunction, and because he was hemodynamically stable, we decided to give him a fluid bolus. Now, a lot of data on fluid boluses for resuscitation, and there is a list of fluids which all of you choose from when you try and resuscitate patients. Normal saline, Ringer's, albumin, multi-electrolyte solutions, balanced solutions, or hetastarch. A lot of controversy regarding fluids, and there have been trials in the last 7 years, the SPLIT trial, the SMART trial, the BASICS, and the PLUS study. And still we are not sure what is the right choice of fluid, because controversial conclusions have come up from each trial. And why are we still harping on fluids? Because as far as fluids is concerned, it is a key component of critical care, and even a small difference in the fluid strategy might make a huge difference to the outcome because it affects each and every patient. So this was a meta-analysis came out in the New England Journal of Medicine this year in March, which looked at which is the best fluid to resuscitate your patients. And the primary outcomes were 90-day mortality, and they had a list of secondary outcomes as well. And there was a clear favor towards balanced multi-electrolyte solutions. So regardless of whatever the trials have said till date, if you are resuscitating your patients today, balanced multi-electrolyte solution is the norm. At least that is so for the time being till we get new trials, but I think we have put a rest to the debate as to which is the best fluid for resuscitation. One line to end it: remember, the fluid strategy is more important than which fluid you give. It is how much to resuscitate, when to de-resuscitate, which is more important than giving the fluid. So this patient was given a fluid bolus with a balanced solution. His hemodynamics improved and he was started on lung protective ventilation. So we come to the next question: does this patient have septic shock? Now the septic shock guidelines came out very recently, and I'm not going to go into the details because a lot will be talked about during this session on septic shock. But just a few things which are relevant to this session. Steroids in septic shock can be given if the patient is on fluids, if the patient is on vasopressors and still has ongoing vasopressor requirements. So they have come out conclusively in favor of steroids. They have segregated septic shock into sepsis and septic shock. Your antibiotics, if the patient is in shock, should be in the first hour. If you are in sepsis, you have 3 hours to decide to give your antibiotics. That cuts down on unnecessary use of antibiotics. And they have pros and cons for several other indications. So capillary refill time is in, empiric coverage with MRSA and antifungal is in, levosimendan is against, HFNC against, NIV is in favor of HFNC, ECMO is for now if you are failing ventilation, and there is a strong against extracorporeal therapies like polymyxin B hemoperfusion. So obviously this patient is in shock, you need to choose an antibiotic. There are several antibiotics to choose from. In my ICU, gram-negative infections is the commonest bug which we are going, and the most common is Klebsiella. Now remember, most of our gram-negatives have a lot of carbapenemase production. These could be KPCs, OXAs or NDMs, and these are only sensitive to polymyxins and TG cyclines. Now this is where the catch is. We've been using polymyxins and TG cyclines extensively in the last few years, and this is where the new guidelines have come in from the IDSA regarding use of antibiotics in gram-negative infections pertaining to CREs, Pseudomonas and Acinetobacter. I would request you to read all of them. They are from the IDSA, came out in 2022. As far as recommendations are concerned, if you are dealing with a Klebsiella, you need to know which enzyme this Klebsiella has, whether it is KPC, NDM or OXA. In India, we have dominance of NDM and OXA. So for NDM, now the recommendation is a combination of ceftazidime avibactam with aztreonam, versus for OXA, ceftazidime avibactam monotherapy with 2. If you are using ceftazidime avibactam with aztreonam, they should be simultaneously infused, not one after the other. Tetracyclines like tigecycline or minocycline and polymyxins are second-line drugs and only to be used in combinations. For Pseudomonas in India, polymyxins still are the drug of choice used in combination because of lack of better options. For Acinetobacter, the hierarchy is you have to base it on a poly B therapy, but the additives are either sulbactam, tetracycline derivatives like minocycline or tigecycline, and you might combine it with carbapenem. There is no role for nebulized antibiotics in gram-negative multi-drug resistant infections as far as the IDSA recommendation goes, but there are other recommendations which have advocated nebulized antibiotics. So this is the take home. You can take this one pick and it tells you what to do if you are dealing with one of these bugs. So we suspected NDM Klebsiella, but actually this patient was started on ceftazidime, avibactam and aztreonam. Now remember, when you send cultures, it takes 24 hours to come back, and you have to judge your antibiotic within a few minutes when you are giving an antibiotic empirically. So is there any way to shorten the duration of this thought process? And this is where multiplex PCRs are coming in, possibly to a great extent into our ICU. So as intensivists, we want to hit the right antibiotic for the right bug very fast. But in doing so, sometimes we end up overutilizing our antibiotics, which contributes to antibiotic resistance and failure of therapy in occasional cases. The multiplex PCR helps us in this way. It helps us in identification of the microorganisms very early, and it also tells us which are the resistant genes. And this allows rapid use of narrow spectrum antibiotics. These are few of the PCRs which we are resorting to in our ICUs. This tells, like, this is the Respiquick PCR from Rivara, which tells us as to which is the gram-positive bug, gram-negative bug, atypicals, acid-fast, fungi, viruses, and it also tells you the target genes. So one test tells you a lot of stuff. And there is data to say that if you are using the PCRs, they are standardized, they are extremely specific when you compare it with blood cultures, and because they tell you the resistant gene as well, it has better performance in choosing antibiotics than going empirically. What is relevant is that if you're using PCRs, the turnaround time is so short that possibly soon we will be having our definitive therapies very similar to empirical therapies. What I mean by that is, if you send a PCR, it comes back at 4 hours. If you are choosing an antibiotic upfront, you take 24 hours before you get a culture. It takes you another 24 hours to know the sensitivity. But with a multiplex PCR, at 4 hours, you know which is the bug, you know which is the gene, and you can target your antibiotics. So your empirical therapy becomes very similar to definitive therapy, and lesser the gap, the better is the time span given to improve the patient. So we send in multiplex PCR. I suspected a Klebsiella. This patient grew an NDM Acinetobacter. So we changed our antibiotics. Remember, for an Acinetobacter, ceftazidime, avibactam, aztreonam doesn't work, so we changed his antibiotics. Now, this patient is on high FiO2 requirements and we needed to prone him. The question is, all of us know that when we treat patients on ARDS, we use a lot of PEEP. The question is, when you prone these patients, does the PEEP requirement change in any way? So this was a study which looked at specifically this aspect. When you prone a patient, should the PEEP levels be modified compared to what it was in the supine levels? And what came out with this study was that as compared to supine position, when you prone a patient, the PEEP requirements need to be dialed down a little bit, because the combination of prone and PEEP gives you the same benefit at a lower PEEP as compared to when you are on a supine position. So when you prone a patient, you can decrease the PEEP without compromising lung recruitment. Hence, this trial clearly showed that when you prone a patient, you get better pressures because the PEEP level can be brought down. Now, the next step was, this patient is an ARDS. We use a lot of steroids for our patients with ARDS. Would you prescribe steroids in patients with ARDS? And if yes, what do you do? So the dexamethasone treatment for ARDS study came out in the Lancet very recently. Again, a multi-center trial. Again, a trial which recruited around 300 patients, a big trial for ARDS. What is important is they looked at pneumonia, sepsis, aspiration. So 80% of these patients of ARDS had pneumonia and sepsis. The intervention was dexamethasone. The previous trials had used hydrocortisone and methylprednisolone. So the therapy was 20 milligrams dexa for day 1 to 5 and then 10 milligrams dexa from day 6 to 10 or till the point of extubation, whichever was early. Again, a trial which favored giving steroids in moderate to severe ARDS. The number of ventilator-free days was less mortality and less duration of ventilation. Clearly a positive trial. Now why DEXA compared to methylprednisolone or hydrocortisone? Compared to the other two steroids, DEXA has a pure glucocorticoid effect. DEXA is longer lasting. The previous trials used steroids for almost 28 days and that adds to the risk of infection. So maybe DEXA is a better option as compared to the other steroids which we end up giving for a very long time. But remember, all these patients, 80% of them was pneumonia and sepsis. So we still don't know that if these patients had extra pulmonary ARDS, would they have responded to steroids in the same way? So the blanket statements that steroids in ARDS are good is not necessarily true. Going to the next few trials, one thing which I want you to take home today is this paper which came out in the intensive care medicine. We have been practicing therapeutic drug monitoring to optimize antibiotics, but it is time we started implementing it on a regular basis. In the ICU, there is intra and interpatient variability in pharmacokinetics and pharmacodynamics in each and every patient. So you do not know what is the optimized dose. Excessive dose will end up hurting the patient, causing toxicity. Lower dose will end up leading to failure of therapy and propagating resistance. So let's start doing this on a frequent basis. Till now we are doing it for voriconazole and vancomycin, but in the near future we might be having the facility and we should subject each and every drug, whether it is beta-lactams, aminoglycosides, vancomycins, teicoplanin or linezolid, and this is the recommendation that please start practicing therapeutic drug monitoring wherever it is available. Last few things, I just wanted to speak a little bit on acute exacerbations of interstitial lung disease. This patient had an ILD in the background, and there was this recent study which looked at ILDs in the ICU, again coming out in 2022 on the World Journal of Critical Care Medicine. Those of you who are respiratory physicians, I would urge you to go through this very well written paper, and it basically tells you that if you have an acute exacerbation of ILD coming to the ICU, you need to know for sure whether you have transplant facility available in your setup or around you, because the prognosis for an acute exacerbation of ILD is pathetic. It's like 90% mortality at 1 year. So if you have lung transplant facility, first channelize this patient towards transplant. If not, send them towards palliative care. The management of ILDs in the ICU is very, very difficult and the survival rate is extremely poor. Cyclophosphamide does not seem to help, and this trial categorically showed that if you have acute exacerbation, cyclophosphamide doesn't work in helping you out. So anyway, coming to the key points of this session, and this is my final concluding slide. HFNO is the new kid on the block and it is making inroads into the traditional NIV and invasive mechanical ventilation territory. Balanced fluids are better and please utilize them for resuscitation compared to normal saline. Newer antibiotics on the anvil should be used as polymyxin sparing therapy. Polymyxins should be avoided as far as possible. Use multiplex PCRs, therapeutic drug monitoring, procalcitonin to optimize choice, duration and de-escalation of antibiotics. There is fine-tuning of the sepsis guideline. Please go through that document. Steroids and extracorporeal therapies in ARDS are here to stay. Practice them judiciously. And prone positioning works in every patient with moderate to severe ARDS, whether it is spontaneously breathing, whether it is high flow, whether it is non-invasive, and of late there are trials of prone positioning on ECMO as well. So practice prone positioning in every patient of ARDS. I thank you for a patient listening and I'm open to questions. Thank you.